super excited about this panel. First, we have Dr. Petros Grivas. Right?
Thank you. Excellent Greek accent. I love it.
You know, I have that fiber. I don't. But he is from the Hutch. He's director of genitourinary cancer, the program there, as well as University of Washington School of Medicine. And then we have Karine Tawagi, genitourinary medical oncologist at University of Illinois, and Dr. Tian Zhang, Dr. Karine, forgive me, long-term friends, associate professor of internal medicine at UT Southwestern, and associate director of clinical research at the Simmons Comprehensive Cancer Center. So let's get into it. First, we'll go ahead and start with prostate, if that's okay. And then we were talking about or looking into a phase 3 study that looked at niraparib plus AAP for metastatic castrate-sensitive prostate cancer with HRR mutations. So whoever feels most passionately about either something that they're excited about or underwhelmed about in here, I would love to hear it.
You know, I think that we're all excited to see it. It's a late-breaking abstract coming up on Prostate Orals Tuesday morning. So if y'all are in Chicago on Tuesday, definitely go. So we don't know the data, but it's a HRR selected population treated with either niraparib with abiraterone or abiraterone. And so I think it's a population that's set up to respond to the PARP. And, you know, I'm really excited to see it. So big phase 3 sets up a lot of good questions and intensification early on for our patients with hormone-sensitive prostate cancer.
Great summary by Dr. Zhang, as always. And I will just say, you know, we're all debating and discussing about the role of PARP inhibition in which therapy setting which is the best suited for. Right now, PARP inhibition is being used in metastatic castration-resistant prostate cancer. That's the data where they are right now, either as monotherapy with olaparib, based on the trial that was done by Dr. Hussein a few years ago, so benefit with olaparib as single agent. And now, of course, we have 3 combination trials, Propel, Magnitude, and Talapro-2. All of them are in metastatic CRPC. So Amplitude is, to my knowledge, as Tian said, the first trial to be reported in metastatic hormone-sensitive setting. So we're all excited to see what this trial shows.
Oh, it's on. And I wanted to add, you know, I think today we saw data from Talapro-2, which is an update from the metastatic castrate-resistant prostate cancer phase 3 trial that we've heard a lot about, one of the combinations. And we heard about some of the responses by the type of HRR mutation. And we know that the type of mutation does matter. So we saw some of the strongest data for BRCA2 as expected, PALB2, CDK12. Traditionally, things like ATM, CHEK2 don't respond as well. So I think paying attention to the mutation also matters somewhat. But I think the sequence of PARP inhibitors has been a question for us even before this data was going to be presented on Tuesday. Let's say, assumably, it's going to be a positive trial. We'll see. But you know, how is that going to come into play as far as triplet therapy, as far as Pluvicto now being approved pre-chemo? So I think that it will just further muddy the water where we already had a question of if someone has one of these mutations, where to use the PARP.
No doubt. And one thing that's, you know, frankly just quite sad is some of this data that's come out showing that really the use, especially in castrate-sensitive, meaning you haven't started ADT, even being referred to see a medical oncologist and still benefit from the stuff that we already do in combination therapy and know better, or, you know, are more effective survival-wise when it comes to combination therapy is still needing to be had. So it's like you have these crazy discussions on like the most optimal way to be able to treat this metastatic castrate-sensitive disease, and yet a common theme, as you heard in the previous discussions with lung and all, not being even referred to MENONC. So like that's, you know, those are the gaps that are, I think, very important.
So to that vein, I think genomically characterizing our patients with metastatic prostate cancer is super important, and doing it early will help us select the right patients for the PARP inhibitors.
Yeah. 100%.
I think so. Like with Tian, we're connected mentally. I was about to say the same thing, that it's so important, the take-home message, you know, for community oncologists practicing, right? Make sure you do both tumor somatic and germline testing for prostate cancer. It's very important. That can help the patient treatment-wise and the broader family cascade testing, cancer prevention. And I think Karine is correct. Mutation matters, and what gene you're referring to matters. So a lot of discussion about, which mutations, which genes, because these are not created equal.
Right.
And the majority of the data so far we have, at least for single agent PARP inhibition, olaparib and metastatic CRPCs with BRCA1 and 2, that's the majority of the benefit there. It's not clear about the other mutations right now, at least with single agent PARP inhibition in mCRPC.
Right. Yeah. Sub classification or just characterization, contextualization of HR, et cetera. So excellent. That's eagerly anticipated on Tuesday. Now moving into bladder, all right, scary disease process has been pretty obstinate. It was recent 5-10 years ago. It was something that was quite challenging. We've gone a long way with targeted therapies and also strategy when it comes to resection and tolerability. Speaking on CREST, Sazalimab, yeah, that, plus BCG in BCG-naïve high-risk non-muscle invasive bladder cancer. Who wants first?
He went
First
to
go.
AOA, so we're going to let him take it away.
I'll do a quick comment, but my dear friends and colleagues can comment too. This is an interesting trial in the BCG-naïve high-risk non-muscle invasive disease space, which is treated by urologists, right? It's a urologic oncologist. So this is a space where medical oncologists have not treated patients, right? It's very early on. So it's very interesting. We have 2 trials right now that reported positive result. One is CREST, and the other is Potomac, like the river. And both trials had similar design. The question of those trials was intravesical BCG alone, induction plus maintenance BCG alone, or in combination with systemic checkpoint inhibition. And that's where the medical oncologists may come to play, depending on where you are. So the CREST trial met the primary endpoints. I think it was recurrence-free survival, and you can argue statistical significant benefits by adding the systemically administered sasanlimab, it's subcutaneous checkpoint inhibitor, with BCG versus BCG alone. You still need the maintenance part of the BCG. That's a take-home message. We saw that today from Tom Powell that showed an update from the CREST trial. So you need the maintenance component of intravesical BCG, and this is relevant because there's a national BCG shortage. So we have challenges. The urologists have challenges getting the BCG. But it seems that the addition of checkpoint inhibition systemically adds benefit. The question is, who are the patients who may benefit more? Are those patients with high-risk disease, CIS, maybe T1? Because the big question is in clinical practice, do we have enough clinic space, enough medical oncologists, enough nurses to treat these patients and follow them for immune-related adverse events? So right now, CREST and Potomac are positive. The drugs are not FDA approved yet, or we're waiting to see what the regulatory agencies will say. But definitely, statistically, you can argue about the clinical significance, but these trials met the primary endpoint. So we may start seeing these patients in clinic, Karine and Tian. And the question will be again, do we have enough oncologists to do that? Because it's a large number of patients with non-muscle invasive disease.
A lot of the LUGPAs are already set up to give some of this. Neil Shore, I'm sure, is raring. But I think, if they're able to manage those complications, or they've hired in, medical oncologists to sort of co-manage patients with them, totally fine. And, it's great to see the activity. So hopefully, sasanlimab is sub-Q too. So it's an easier formulation to give. So a lot of good, positives of CREST trial.
And the other, I agree with you 100%. The other question is then recurrence-free survival of recurrence of high-grade urothelial carcinoma. Very few patients had progression to muscle-invasive disease. Very few had metastasis. So the endpoints like metastasis-free survival or cystectomy-free survival were hard to show because of the low numbers. So the big question in the urologist's mind is the potential risk of immune-related adverse events worth the benefit from reducing high-grade recurrence, high-risk recurrence? And that's a big question right now. We have to figure out in the clinic, how do you use the agents, which patients, how can we potentially select the patients who benefit more? I don't think we have the answers, but I think it's going to be interesting to see how this plays out if that drug gets approved. Do we consult all those patients? Some of them, it remains to be seen.
Yeah, again, like subclassify or contextualize that risk to benefit ratio based on the higher risk profiles and the potentially need for larger benefit, for sure. And speaking of for sure, SURE 02, sacituzumab plus pembrolizumab in muscle-invasive bladder cancer. Karine, you want to take a shot?
Sure, I'll take it. So Dr. Necki presented this yesterday. So it's interesting, this trial. It's sacituzumab, pembrolizumab in the neoadjuvant setting, and then you do bladder preservation. So you're not doing chemoradiation, you're not doing cystectomy, and then they looked at clinical complete response. I think it was about 37% of patients that had a clinical complete response. But the other thing to note here is that the dosing of sacituzumab is 7.5 milligrams on day 1 and day 8. They gave GCSF with this regimen. They also checked UGT1A1 to look for greater toxicity. There was not increased toxicity with any polymorphism in UGT1A1 in this trial. But I think in the muscle-invasive bladder cancer space, we have the Niagara trial, which we're going to talk about soon, which is our new standard of care in cisplatin eligible. But we have a lot of questions both for cisplatin ineligible and for all of the patients that want to keep their bladders in or not go through the toxicity of radiation. So I think there are a lot of trials in this space right now. There is another trial called BRIGHT, which will also look at chemoradiation post-neoadjuvant chemotherapy. But this is a high area of interest as far as quality of life for patients. So sacituzumab, had an approval in the metastatic space, and the FDA label was revoked last fall. But now there's activity in bladder cancer with sacituzumab. The question is, where is it going to fit in? And this had some activity. The space is evolving as far as muscle invasive, so that is to be seen. But
yeah, I know Gilead voluntarily withdrew that label after TROPiCS-04, which you wonderfully presented at ESMO Asia, and it was recently published. So, I hope, and there are some patients who might benefit from sacituzumab govitecan. We certainly have treated them on label in our clinics. So the question is, can we pre-select those patient populations? And, will there be a follow-up, right? This is a phase 2 trial, so could there be some, future activity for sacituzumab still in bladder cancer?
Fantastic comments by both Karine and Tian, and I would say with TROPiCS-04 trial, the phase 3 trial with sacituzumab govitecan versus taxane or vinflunine, it was a negative trial, as Tian rightly said. And that trial, going back in time, hindsight, big question in my mind is, if we had mandated primary prophylaxis with growth factor, would that have changed potentially the result? We don't know, right? But definitely the primary prophylaxis with growth factor, I think, plays a big role, try to reduce the risk of blood neutropenia, because we saw a very concerning number of grade 5 neutropenic events that may have been prevented if we had a mandatory primary growth factor prophylaxis. So, it's something that, it's always in my mind, would that have changed? And to your points, if I use sacituzumab govitecan as monotherapy, for metastatic urothelial carcinoma, I do it in later lines after I exhaust life-prolonging therapies. It's listed at NCCN guidelines, despite the FDA withdrawal, as you said. If I use it, carefully selected patients after prior therapies, and I use growth factor as primary prophylaxis. The combination of such pembro in that setting, as Karine said, is hypothesis generating. And the question is how you design future trials. We're actually designing a phase 3 trial with SACI plus pembro in metastatic disease with cooperative groups, ECOG-ACRIN, and if it goes through the CTEP mechanism, we're trying to compare SACI plus pembro versus chemotherapy in metastatic urothelial carcinoma in patients with prior checkpoint inhibition, trying to answer the immunotherapy challenge question, which is a big question in the field. So we'll see whether the trial will go forward or not.
No doubt. In speaking, at least in the bladder preservation element, unlike some of the things that we talked about previously with pancreatic and colorectal and kind of that age decision on how aggressive on the borderline resectable, and correct me if I'm wrong, but bladder is generally still, the age population is consistent. So these things are hopefully more relevant to things and considerations that may differ in younger populations, et cetera. So like that bladder preservation or full cystectomy, it's a big problem in geriatric patients, especially those that are smokers and getting these kind of cancers to begin with. So moving on, because there's a lot of good stuff to discuss. EV302, a subgroup analysis on EV plus pembrolizumab in the first-line setting of metastatic urothelial. Exciting?
Great trial, and to Jackie Brown's excellent discussion earlier today, it's a winning lap, right, for EV302. So to look at that subset analysis for people who had complete and partial responders, I mean, these patients are doing really well. I had patients in my own clinic on EV302, and if they've achieved a complete response, one of them kept his bladder and has no intraluminal recurrence. He's off treatment for toxicity, but he's 2 years out without treatment. Some of them are living, treatment-free survival intervals, right? When did we ever think about that for metastatic bladder cancer? So absolutely fantastic. And these durations of responses were great. If people can achieve that complete or partial response on EV pembrolizumab, it's a great, long-term outcome for them. There are some progressors, right? There are some resistance that occurs. There are some primary progressors. So we do need to learn more about this patient cohort, about EV pembro. But, for the people who do achieve those durable responses, it's fantastic.
Very nicely said, and I want to hear Karine's comments too. I think this trial is really, not only practice changing, but paradigm changing. The first time we're able to beat platinum-based chemotherapy in the frontline setting. And when we saw the data at ESMO 2023, there was a big applause, standing ovation in the room. I think there are many questions still open. Obviously, to your point, Tian, the depth of response matters. If you have a complete response, 3 out of 4 patients are able to maintain that at 2 years. That's great. The durability is not as robust in partial responses, but still many patients may maintain that. The big question is de-escalation of therapy. When do you de-escalate? Dose adjustment modifications? Do you ever stop? At which time point? When you have a CR, depends on toxicity. Do you use ctDNA or not? I don't think we have the answers. We play it by ear in each patient. And toxicity is a major driver for that.
Yeah, I would agree. Some of the data that we heard today was also the median number of cycles was 12, but for patients that respond, they may be up to 30 cycles. And the discussant also made a great point about grade 2 neuropathy and how disabling that can be, that or even greater grade neuropathy. But how can we avoid getting to grade 2 neuropathy? Because that is disabling. And can we think about, we'll talk about ctDNA in a minute in muscle invasive, but can we think about ways to perhaps think about de-escalation so we can de-escalate before getting to that grade 2 neuropathy for the people that maybe don't need that extended duration? We don't know the answer to that yet.
No doubt. It's such a paradigm shift. I mean, if you would talk to someone 10 years ago about that break-free interval, like you said, in metastatic urothelial, it's just wild. Tian, I remember you had a lecture, I don't know if I saw it online or in person, about really this role of circulating tumor DNA in further, again, subclassifying or characterizing, how we think about giving treatment in a perioperative manner when it comes to durvalumab in muscle-invasive bladder cancer, and how if you subclassify and characterize the circulating tumor DNA being positive versus not, maybe we need to revisit the consideration of the benefit, obviously, and that's one of the challenges of, improved technologic assessments or scientific assessments and depth of insight to then going backwards and saying, are we sure it does or doesn't matter? So, and you had mentioned it earlier as well in the Niagara trial. Tell us about kind of what we heard and how we think about that when it comes to this newer technology of knowing of the DNA presence or not.
Sure. So Dr. Powell's presented data on ctDNA today, and they checked ctDNA before starting neoadjuvant gemcis durva, before cystectomy, and then post-cystectomy. And then 57% of patients had positive ctDNA at the beginning, and then I think an additional 20 or something percent converted after neoadjuvant treatment. There was greater improvement with durvalumab regardless of the ctDNA. And then some of the other interesting findings, I think, post-cystectomy, that a positive ctDNA was associated with non-pathologic CR, as probably would be expected. But I think that this is one of the most robust maybe presentations that we've had about the use of it when we are in a clinic next week thinking about when to order it and how it could correlate to some of the, second surrogate markers.
It's a marker for minimal residual disease, if we will, right? And in solid tumor, we haven't had a marker like that. but it's not perfect. So we saw positive ctDNA. Folks have poor prognosis in terms of disease-free survival. The patients who had ctDNA negative, they still had some recurrences, so it's not fully foolproof. So that was my first takeaway from it. Durvalumab works in both populations, but those patients with ctDNA positive disease, those are the patients who have a higher risk for post-cystectomy recurrence, and so those are the people that I might really think about more intensifying treatment. So to your point earlier, the ctDNA data really came out from the IMvigor010 adjuvant trial, where atezolizumab was shown to have some benefit in that adjuvant patient population. And it really drives the trial design for a trial in the Alliance now called MODERN that Matt Galsky leads. And it is stratified by ctDNA positivity. So patients with ctDNA positive disease post-cystectomy are randomized to nivolumab or nivolumab with relatlimab, so intensification in that high-risk population. And then the patients with ctDNA negative disease are given nivolumab alone, or waiting until they convert to ctDNA positive to start nivolumab. So I think both critically important questions of, do we intensify therapy for those at highest risk? And then in those patients who may not be set up to recur, could we, wait until starting nivolumab? So it's a great trial. We're enrolling to it at UT Southwestern, and so I think ctDNA as a biomarker, we have much more to learn, but it was really nice to see that correlation in Niagara today.
Very interesting data. Great points by Tian and Karine. I think, for me, has still been a debate in my mind, should I use ctDNA or not in this muscle-invasive bladder cancer stage, and many colleagues in the community call me and we're discussing that. I try to think about, if I do a ctDNA testing, we know for sure it's very highly prognostic. As you said, Tian, we know that ctDNA is highly prognostic in those patients. The big question is how it's going to influence my management in this disease setting. Am I going to change my decision based on that? I don't know yet. I'm not convinced about the predictive role in that setting. And the data today were interesting to me because, again, it's an exploratory ad hoc analysis, all the caveats and limitations, but it appeared to me that the benefit with the adjuvant phase of durvalumab may be regardless of the path-CR and regardless of ctDNA, even ctDNA negative patients. So if anything, I'm going to continue my practice to offer both neoadjuvant and adjuvant durvalumab, acknowledging that I'm going to overtreat some patients and the risk of toxicity and cost and therapy burden. But I'm leaning towards offering that, these 8 monthly adjuvant doses based on the current data until we know more.
Don't get a false sense of security or not give something that could have benefited.
Yeah, it's risk of overtreatment, risk of undertreatment.
Yeah, 100%. Moving on to RCC, and I really appreciate all of y'all's insights on these different but very interesting updates. Keynote 564. It's a 5-year follow-up on phase 3 study for adjuvant pembrolizumab in clear cell renal cell carcinoma. I mean, when we first started noticing how, effective IO can be in RCC, I got very excited. Tell us about this 5-year follow-up. Doesn't have to be everybody, because I really want to get to pedigree as well. But what do we see and what do we find?
Well, Naomi has presented the 5-year survival follow-up and ongoing overall survival benefit across the population, high-risk disease. I do think, we talk a lot about adjuvant IO and kidney cancer, and there's some hesitancy in the communities about using IO therapy because there's been 3 or 4 negative trials, but 564 is the only positive one and the only one to show overall survival benefits across the last many that have been done in adjuvant kidney cancer. So I think we need to find the patients at highest risk for disease recurrence. To your point, if we don't want to overtreat, then who are the patients at high risk who will benefit most from adjuvant pembrolizumab for a year? So very confirmatory to what we already knew, but it's really good to see that ongoing prolonged overall survival benefit.
Yeah, and the STRIKE trial is enrolling now, and that's adding tivozanib to pembrolizumab to further see versus pembrolizumab to see if there's a benefit.
Good point. Pedigree. Step 1 analysis of adaptive Nivo-Ipi with a cabozantinib in first-line metastatic renal cell.
Yeah, so my baby, my fourth child, it's actually
11
older
years
than
old.
my third one.
11 years old.
11 years old. So this is a trial we've been working on in the Alliance Cooperative Groups for many years, and with the support of Tony Schwery and Dan George and Mike Morris. But we, launched in May of 2019 and enrolled over 5 years until May of 2024. So we analyzed the step 1 demographics as well as assignments into the randomized cohorts for this analysis at ASCO. And we, really showed, there's some drop off in step 1 with any adaptive real world trial. We're going to have some drop off, but we enrolled a very heterogeneous population, diverse population, 10% Hispanic, over 8% Black, Asian, and American Indian. And then in terms of disease characteristics, about 76% were intermediate risk disease, 23% poor risk disease. In the poor risk population, there were fewer that enrolled into step 2 than discontinued in step 1. So we know those patients are a little bit more frail, and so they're not quite robust enough to get to step 2. Also, fewer patients with bone metastases made it into step 2. So those patients also we know to have poorer prognosis and a little bit more symptomatic. So Ipi-Nivo, great combination and certainly standard of care in many of our practices. I think as we're learning which of the patients can get through 4 cycles of Ipi-Nivo, this is sort of the first step in sort of thinking about those patient characteristics. And then our primary endpoint is overall survival. And so the longer we wait, the better for our patients. So we're still waiting for that outcome. And hopefully it'll be in the next year or 2. But, I think it's a good way to sequence immunotherapy doublets if it does turn out positive and not wait until disease progression to do that.
I just want to say, congratulations, Tian. This is a huge effort, huge, monumental work. Yes. By the way, I have coffee here. There's no Greek ouzo involved. I don't know. Want to make this disclaimer. Huge effort. And I remember those days. You work with Tony and, Dan and Mike to get this trial up and running. This is, a huge effort and looking forward to more results. But I think it's helpful to see the data in a large population of patients, right? If I remember, 1,111 patients.
That's right.
One. So, right? So it's to remember. Yes. And one question that Brian Rini had to you was, the complete response rate with Ipi-Nivo was lower than expected. And, you answered, maybe the population of the patients, the baseline characteristics, obviously, that kind of play a role in a real world setting, all those factors may play a role.
Now, we had more de novo metastatic disease than Checkmate 214 that this trial was based off of. And then also we know median time to complete response on 214 was about 7 months, so a little later than when we randomized. And the patients with de novo metastatic disease in 214 is probably about 20%. And so if you looked at those patients, Laurent Salvijas had a subset analysis of 214 that showed that if you had a primary intact, those patients do not achieve CR. Those large, bulky kidney tumors just don't shrink to 0. And so even if they're cystic and they're pathologic T0, they don't get to 0 for measurable disease. So I think all of those, factors into the 3-month, those patients are still single digits, right, for the complete responders at 3 months, but not too unexpected considering.
Amazing.
Great points, yeah.
Karine, tell us about ARC-20.
So I'll just start to talk about the HIF-2 alphas that are approved in this space, and then I'll have them take it away on ARC-20. But we know that we have belzutifan, HIF-2 alpha inhibitor, approved post-IO TKI. Tony Schwery presented data on ARC-20, a novel HIF-2 alpha inhibitor in combination with cabozantinib. And I'll have them tell us about the results.
So casdatifan is a new kid on the block, right? New HIF-2 alpha inhibitor. We saw some of the ARC-20 cohorts for monotherapy. So there's a disease activity for the monotherapy in refractory clear cell kidney cancer. Response rates are around 25 to 33%, depending on dose. And so today, Tony Schwery presented the combination of casdatifan with cabozantinib, showing an objective response rate of about 46.8%. If I remember correctly, and about 24% grade 3 anemia. So something we still need to watch out for in this patient population. But of note, it sets up very critically a phase 3 registrational trial that's about to launch. It's called PEAK-1 with casdatifan with cabozantinib randomized to cabozantinib alone in a 2-to-1 randomization. So I think more to come. Tony made this point at the end of the session of, more competition, the better, and, having a newer agent is an interesting, as belzutifan is now being developed in earlier disease settings of kidney cancer, maybe casdatifan then fits in the picture in a later disease setting. So I think more options for our patients is always great.
And the big question that comes in my mind, Tian, I remember also some data from ESMO 2024 from another compound, a different compound, HIF-2 alpha inhibitor. And the question that came to my mind is, do we know anything about mechanisms of resistance that can help inform a potential sequential approach into those agents or not yet?
Jim Brugerolis' lab has characterized some in the HIF binding domain of belzutifan where dimerase is. There are mutations that are point mutations that confer resistance, where belzutifan and its similar compounds will not bind. I don't know if he's tested those, tumor models with casdatifan. I think he should. But if the casdatifan is shown to have activity, even with those resistance mutations, it would be great, to have patients, even if they become resistant to one HIF inhibitor, still have activity with another. We'll be mimicking the lung cancer EGFR stories at that point, but it would be a good problem to have.
It will be interesting to see the preclinical work that Jim is doing great work there.
Excellent. Well, thank you all so much for this. This is extremely edifying, and hopefully you all get as excited as I do. So if we can give a round of applause for your insights.
Thanks for having us.
Yeah.
Thank you.
Thanks so much.